So Dr. William Torelli went to Penn State University for his undergrad, and he had degrees in both microbiology and biochemistry. He then went to medical school at the Philadelphia College of Osteopathic Medicine, and he did his internal medicine residency at Geisinger Medical Center. He also did a rheumatology fellowship at Lehigh Valley Health Network, and he has additional training in musculoskeletal ultrasound with US Sonar, and he's certified by RHMSUS, maybe you can explain that to us later, in the use of musculoskeletal ultrasound for diagnosis and treatment of arthritis. So I think without further ado, you can get started now. Thank you.
All right, sounds great. So gout, very near and dear to my heart. We're going to talk about a lot of different other microcrystalline diseases throughout the course of this talk, but we can't talk about microcrystalline disease without talking about gout. So that's a picture of the gout gremlin. It's a depiction. I think that, like I said, that picture paints, a picture's worth 1,000 words, and I think a lot of my patients could, relate to, how that may feel. So this is a very common presentation when we think about when we're talking about microcrystalline disease. So you may have a patient, 35 years old, history of alcohol abuse, maybe 6 beers a day, obesity, psoriasis, comes to the ER with complaints of left knee pain, erythema, and swelling for the past day. Patient had a pain similar quality 5 months ago on his left first MTP that resolved over 2 weeks without any treatment. This go around with the knee, he was at a Memorial Day barbecue and he was drinking beer, eating hamburgers. That was the day prior to presentation, and he cannot walk at this point. He's never had an arthrocentesis to prove the presence of microcrystalline disease, never had a kidney stone, and has never been on therapy for gout. Past medical history that we know of, psoriasis and obesity. He's had his gallbladder removed. He's had a hernia repair. Mom, just to add some wrinkles, mom had history of RA, has history of RA, and dad has gout. Also paternal grandfather with gout. Drinks 6 beers a day, does smoke, lives at home with his wife and son. He's a computer programmer, and he's allergic to sulfa. So physical exam, just kind of cutting to the chase, I think, again, I have a lot of pictures in this presentation. I think that really kind of helps drive home some of the points. So when you're thinking about an inflammatory arthritis, the joint's going to be warm, it's going to be hot, there's going to be an effusion, especially for microcrystalline disease. But the biggest thing that I would ask you to do in a situation like this when you're doing an exam was, can the patient range of motion their knee? If they can bend their knee, and still, it would be painful, mind you, but if they can bend it, I'm worried. I mean, septic arthritis is still in the differential, but if they can range of motion their own knee, I'm starting to think more about microcrystalline disease. But again, workup, there's a differential. Workup is still important. So kind of moving along, what is your differential diagnosis at this point? Well, it's septic arthritis until proven otherwise. That is what's going to hurt the patient. That's what's going to cause potentially morbidity, mortality. So that should be first on our minds. Gout and pseudo-gout come to mind. Hemarthrosis lower on the differential. I really don't think flare of OA. Sometimes you can have an effusion from OA, but it's not going to look like that. It's not going to be red, hot, and warm. I said there was a history of psoriasis in the patient. They can have effusions, but they're not. They don't usually examine so inflammatory on exam. Do they? Is it any kind of meniscal injury leading to infusion? I guess lower on the differential. But the main 3 things I want you to think about when you see someone that has an exam like this is a septic arthritis, gout, and pseudo-gout. And this is a picture of someone getting an arthrocentesis from the medial aspect of the knee. And what I would like to draw your attention to is the color of the fluid coming out. If somebody had OA, you'd be able to hold up that syringe, turn it around, and read the numbers on the other side of the syringe, kind of through the fluid. But the consistency of this fluid is very turbid, very yellow. Very, if you were to turn that syringe, you would not be able to see any of the numbers on that side. So, that's what an inflammatory fluid will look like. Does that, and it doesn't distinguish between gout, microcrystalline disease, and infection, but and sometimes with infection you can see purulence as well. So Lyme disease will also be very inflammatory as well. So there's still studies that should be done. you know, when we tap this gentleman's knee, you know, we take a look and we send it, you know, the first thing we're doing is sending it for Grand stamen culture, and that all came back negative. But, you know, I wanted to kind of briefly touch on, you know, what the crystals would look like. So, you know, in gout, we have negatively befringent crystals. They're typically needle shaped versus the positive, like bifringent rhomboid shaped crystals that we see in pseudo-gout. And the main point I want to make with this slide is that, you know, the monosodium urate crystals of gout, you know, they're kind of an innocent bystander until the white blood cells try to engulf them. So on the left-hand picture, you have, you know, white blood cell engulfing, you know, one of the MSU crystals, which leads to an inflammatory cascade, which leads to proliferation and recruitment of more white blood cells to the joint space, and that's what leads to all the pain and swelling. If there was no response, if there was no immune response to the MSU crystals, it'd kind of be like more free floating, like we see in the right-hand picture. You know, that would so the left-hand picture would be, you know, somebody that's having an acute flare of gout. If you take a look at their synovial fluid analysis under the microscope, on the right, you know, that could be in the critical stage. We'll talk more about that in a little bit. Or it could be, you know, maybe you hit a tophus, you know, when you were aspirating, and there's just no cellular material in there. It's just monosodium urate crystals. So that's a consideration. Now, if you tap somebody's joint and it comes out like that, you know, that's more purulent. You know, I'd be worried about septic arthritis in a scenario like this. So keeping that in mind, just kind of looking at the fluid as a whole. So, you know, when we talk about arthritis, you know, rheumatologists like to say, is it a monoarthritis? Is it oligoarticular? Is it polyarticular? Is it symmetric? Is it asymmetric? You know, is it acute, chronic? So I would call gout either a mono or oligoarticular, asymmetric, acute inflammatory arthritis. You know, oligo being less than equal to 4 joints involved, and poly being more than 4 joints involved. And when we think about gout, we think about, you know, is the patient an overproducer or an undersecretor of uric acid? So undersecretors, I tend to think about patients that have, you know, chronic kidney disease. You know, are they just not able to, you know, get rid of urate in the urine? Or are they making too much uric acid after they have purine-rich foods? Do they have any kind of abnormalities in xanthine oxidase enzymes that lead to accumulation of uric acid? And we'll talk more about that in a little bit. But, you know, typically, if you don't do anything, a gout flare will resolve between 5 and 14 days in most cases. It can, most commonly, classically, like we like to teach our medical students, that it likes to involve the first MTP. We call that podagra. Conagra is another version of gout that likes to affect the small joints of the hands. And you know, I say that because, you know, uric acid crystals tend to precipitate out of solution at colder temperatures, and that's why, you know, you tend to have more involvement of the, you know, the distal, the fingers and toes, especially for tophaceous gout, you know, in the fingers, and then obviously MTP in the toe. But not limited to that. You know, we see it a lot in the knee and the ankle, the tarsal bones. You can have it pretty much anywhere except the spine, although there has been case reports of that as well. Very rare. So, you know, gout is the most common inflammatory arthritis in men less than 50 years of age. It likes the first MTP. I was just kind of alluding to the other sites, you know, the forefoot, instep, ankle, knee, wrist, olecranon bursa, you know, and the fingers. And it can, you know, it can be precipitated by other things, you know. If they're on the cardiology ward and they're being diuresed, diuretics can certainly predispose someone to a gout flare. You know, we all know about thiazide type diuretics, and also infections post-operatively, you know, can also predispose for a gout flare. And I'm kind of talking about the stages of gout. So you have stage 1, I guess we could call asymptomatic hyperuricemia. We'll talk more about that in a minute. Stage 2 would be an acute flare of gout. Stage 3 would be, you know, this intercritical period, so the period in between flares. And the worst, you know, scenario for gout is if you have chronic tophaceous disease, and the disease can be complicated by you know, erosions and tophi and destructive arthritis. And I'll show you pictures of erosions and tophi in a moment. So asymptomatic hyperuricemia, don't treat this. You know, they're not, you know, don't treat asymptomatic hyperuricemia. If they have kidney stones and they're, you know, found to be urate stones, then maybe. But you know, at puberty, serum concentrations of uric acid increase by 1 to 2 milligrams per deciliter. And most patients that have hyperuricemia remain asymptomatic for their entire life. So, you know, and you could be hyperuricemic for 15 to 20 years before you have your first, you know, gout attack. So just because somebody's hyperuricemic does not mean they warrant xanthine oxidase inhibition. But it's good to note. Again, some other precipitating factors, you know, alcohol. We tend to think that beer is the worst, followed by liquor and wine. Shellfish, lobsters, crab, shrimp, organ meats like liver are very notorious for causing gout flares. Red meat also is notorious. Chronic kidney disease, like we were talking about, heart disease, especially when somebody's being diuresed. But, you know, patients that have a metabolic syndrome, obesity, are more prone to, you know, developing gout. Trauma, infection, surgery. Aspirin can, you know, be a risk factor, but I'm not going to begrudge somebody their aspirin, especially if they've got coronary disease or, you know, have had history of CVAs. You know, so we just tolerate that. In terms of diuretics, like hydrochlorothiazide, if they're on that for blood pressure, considering alternatives. But, you know, malignancies and diabetes can sometimes be risk factors as well. So, you know, usually we don't see tophaceous material on an x-ray, but this is an example that you can see a lot of soft tissue swelling, you know, around the first MTP in this area here. And there may be some calcifications in here that cause it to light up, but, you know, that's what something like a tophus would look like in an extreme case. Now, these are kind of zoomed in pictures of what an erosion would look like. So in rheumatology, we call these Martel erosions. You have this overhanging edge, you know, and it's not specific for gout, but when I see an erosion like that, it certainly makes me suspicious, especially if it's in the first MTP. You know, but it's not specific. You know, rheumatoid arthritis, psoriatic arthritis will do this as well. So you can't hang your hat on just seeing an erosion on x-ray to make the diagnosis. But it does support the fact they've got an inflammatory arthritis. So it's good to be able to kind of, you know, examine your own images when you order them to, you know, sometimes these things get missed. And this is a picture of someone that has a big tophus. So, you know, tophi come in all shapes and sizes. They like to affect different parts of the body. Elbow, you always check somebody's elbows for tophi. Other common places, and, you know, on the ear, not common, but they happen often enough. And the toe, I see this more often in the toe in the first MTP, and, you know, in the fingers too. It can get really bad, you know, especially if someone just hasn't been treated for, you know, years and years and years. It could take 10 years to absorb some of the tophi that we're seeing in this picture. So it's, you know, it's not going to get better overnight. This is going to improve this, we're going to have a pretty compliant patient that's committed to staying on therapy. As Marcia alluded to, I do have an interest in musculoskeletal ultrasound. You know, obviously the way that we prefer to diagnose this illness is going to be arthrocentesis, but there's not always an effusion to tap. And if you're in a situation like that, you know, you can always grab, well, you know, they can send the patients over and we can ultrasound their ankles and toes, and, you know, we can see what we call the double contour sign in this image. So this is an ultrasound of someone's ankle. You've got the tibia here, and then your talus is here, and then above the talus is this double contour sign. So we believe that this is just an accumulation of uric acid above the talus that gives us this extra hypoechogenic appearance. I'm sorry. And then this would be, again, the double contour sign in someone's first MTP. And, you know, right here, if you follow my mouse along, this is the synovial reflection. You know, so this is the synovial membrane of the joint space, and there may be actually a little bit of tophaceous material here as well. And this is, you know, imaging modality that I just found out that we have access to. This is a dual phase CAT scan. If you don't have anybody that has expertise with the ultrasound, and you don't have something to, you know, if you don't have an effusion to tap, this can sometimes be helpful. I'll be honest with you, I've never had to order this test. But, monosodium urate crystals allegedly turn up green on this test. So you can see on the left-hand side that, that patient may be suffering from gout. It's not a widely available testing modality. So treatment considerations, often one chooses not to initiate chronic pharmacologic therapy after the first attack. That's true with a couple exceptions, and we'll talk about that in a second. Everybody's allowed to have one gout attack, unless they've got a couple exceptions, which we'll talk about. Some conservative treatments. You could talk about weight control, avoidance of high purine foods, like we talked about. Again, we're not going to tell people not to take their aspirin, so disregard that. But thiazide diuretics, certainly there are other options for blood pressure control. And you just got to educate the patient about, if they've had a gout flare, it's likely to happen again. And typically 60 to 70% of people will have a flare within 1 to 2 years of their first gout flare. And, you have to think that once somebody's had their second flare, the third and the fourth flare, there's going to be less time in a critical stage in between flares. So, once they've had that second flare in a year, this is just going to come back more frequently and it's not going away. So it's something, and that's a scenario that you really have to start considering treatment. So what do we use to treat gout? Well, we're rheumatologists. So, we tend to use steroid. There are other options, but we go to these annual meetings, just like internists. We have our American College of Rheumatology, and we all get together and we talk about, management of our disease processes. And a lot of the gout folks are saying if you're using NSAIDs, you're just messing around. But I could be convinced to use NSAIDs in a brittle diabetic or somebody that has other comorbidities that, really terrible heart failure. That I would kind of actually taking that back. Anybody that has heart pathology, avoiding NSAIDs if you can. But, there are scenarios where I could be convinced to at least try, NSAIDs. But for the most part, most patients require, some taper of steroids. And this is a generic taper. Typically, I started at a 0.5 milligram per kilogram, and I wean down by 10 milligrams every 3 days. If somebody's having a pretty severe flare, I would maybe extend this out to 40 milligrams for 5 days, 30 milligrams 5 days, 20 for 5, 10 for 5, and then stop. But a lot of it's based on your clinical judgment. So you just kind of have to, just kind of use your judgment. There is no study to tell you what dose of steroids to give someone in an acute gout flare. If somebody has just 2 joints involved, you could always talk about doing an interarticular injection. Some rheumatologists will go up to 3. And if somebody's having a really awful flare and they've had issues with absorption, you can always talk about, having them admitted for IV Solumedrol, or let's say they can't hold down oral for some reason, that would be another consideration. I like colchicine more for prophylaxis. I typically use 0.6 milligrams PO daily. If somebody's got a GFR less than 30, I'll use Monday, Wednesday, Friday dosing of colchicine. And you can use colchicine in an acute scenario, but the only time I would use colchicine in an acute attack of gout would be as if the patient's had less than 24 hours of, in a flare. If somebody's been flaring for more than 24 hours and you try using the acute treatment with colchicine using 1.2 milligrams PO followed by another 0.6 milligrams 1 hour later, that would probably not work in someone that's been flaring for more than 24 hours. It's definitely worth a try in someone that's had less than 24 hours of a flare. NSAIDs, again, there's lots of different ones, not particularly effective to completely relieve the gout flare, but here's a list of some. Another more interesting medicine that we use very infrequently would be anakinra. I use this maybe twice in my fellowship. It's very expensive. It's a daily injection. It was used on inpatients. And they had some kind of compelling reason not to use steroids. One of the patients was, every time they got steroids, got very encephalopathic. So we ended up using anakinra in that scenario. And, we used it for, 3 to 5, use it 3 to 5 days. And it's just not practical. It's very expensive. You can only really get it on an inpatient basis. And, It is effective, but it's just not practical. Indications for urate lowering therapy. So I kind of talked about this. If someone's got tophi, you treat them. I mean, they may have developed tophi. I find it hard to believe it would be their first flare and then they've already got tophi. But if they've got tophi, you must use urate lowering therapy. If they've got erosions, you certainly should be using urate lowering therapy. If they've got chronic kidney disease or uric acid stones, you should be using urate lowering therapy. And if they've had 2 flares in a year, that would be the time to start. Now, allopurinol. This is the mainstay for the treatment of gout, and it's an xanthine oxidase inhibitor. There's new recommendations by the ACR. We always checked an HLA B5801 in the Han Chinese because of concerns for allopurinol hypersensitivity reaction, which is combination of steroids, rash, eosinophilia, hepatic LFT, abnormalities, and acute renal injury, and in some cases GI bleeding. So we were always checking that for the Han Chinese because they carry that allele. But the new recommendation is in African Americans to actually check this test because they're at a higher risk than the general population for having the allopurinol hypersensitivity reaction. I think this is gaining. It's a new recommendation, and it will build steam over time. But allopurinol is an xanthine oxidase inhibitor. How do we use it? Okay, this is, I think, probably the most important thing in the talk. When you're treating somebody with allopurinol, you should be treating to a target. Okay, the new recommendations for the American College of Rheumatology is to treat somebody with allopurinol at increasing doses until they have a uric acid level less than 6. Now, if somebody's got healthy kidneys, usually what I'll do is I'll try to get them to about 300 milligrams quickly. I'll say, to increase by 100 milligrams every 10 or so days until we get to 300. And that will, for the majority of your patients, get your uric acid level to less than 6. If they've got erosions in tophi, you could make the argument to bring their uric acid level down to less than 5. That is not part of the new guidelines, but anecdotally, I've seen patients flare that were tophaceous that had a uric acid that was less than 6. So, and guidelines are just that. We use them, but clinical judgment also comes into play. So what I want to stress is that, you're checking uric acid levels monthly on these patients. And, if their uric acid is less than 6, I would increase them by 100 milligrams and then check them in a month. If it's less than 6, increase them by another 100 milligrams. You can go all the way up to 800 milligrams of allopurinol. So you've got room to increase. So, I would recommend keeping, having them get monthly blood work until we get to that point. Should you check a uric acid level in someone that's having an acute flare of gout? The answer to that question is yes and no. Okay. Yes, because, if they have hyperuricemia, it may clue you into the diagnosis. It doesn't make a diagnosis. Arthrocentesis makes a diagnosis. But if it's high and they've got a monoarticular arthritis and, you can't, there's nothing to tap, or, it can clue you in. But don't hang your hat on that. If someone's having an acute gout flare, their uric acid levels could be low in that setting, because where's the uric acid? You're testing their blood, but the uric acid's in their joint space. So, in the certain scenarios, somebody's uric acid could be artificially low, and you wouldn't know that they have gout because you tested them during an acute flare. So don't hang your hat on a uric acid level in someone that's actively flaring. But yeah, the most important thing in this talk is treat the gout patients to target. Get their uric acid levels less than 6, or in my opinion, less than 5 in patients that have erosions or tophi. Now, there's other xanthine oxidase inhibitors. Febuxostat is another one. It goes by Uloric. You can use this in people that have allopurinol hypersensitivity. It's easier to titrate because, there's only really 2 doses. You can go up to 120 milligrams in Europe. Here, we try to avoid that. But it's easier to titrate in CKD patients, and not as much of an issue with the allopurinol hypersensitivity. There was one study citing the possibility of increased mortality in patients that have coronary disease. That study design was flawed. A lot of those patients were on NSAIDs, and we know that NSAIDs should be avoided in people that have coronary disease. So that's something to kind of keep in the back of your mind. And then another point I wanted to make is if you have somebody that needs allopurinol and they have chronic kidney disease, best to send them over. But if you're going to start them on allopurinol, I wouldn't start them on any more than 50 milligrams. And you titrate slower in the patients that have, GFR less than 30 or so, because, they're at a higher risk for this hypersensitivity reaction. Probenecid is a drug of the past. We don't really use this anymore. It's only good for under excretors, and you should really be doing a 24-hour urine to check for, how much uric acid they have in their urine. It's really just something that we've kind of moved away from over time because, allopurinol treats both under excretors and over producers, and you don't really have to do this urine test. But, it has eicosuric effects, so it inhibits tubular reabsorption of urate at the proximal convoluted tubule. Now, pegloticase, this is an interesting medicine, and I would only consider a medicine like pegloticase if you've got somebody that has, remember that picture of the hand I'm about to show up again here, that picture of the person that has awful tophi. Let's try to get back to it. This is the person that I would put on pegloticase. Okay, I'm not going to put someone on pegloticase that has had their first flare. It's somebody that has awful tophaceous gout, and it's a uricase, so it actually ends up breaking down uric acid. It's a chimeric. It's an enzyme mammals do not have, and we don't make, and it breaks down uric acid into allantoin. So you have to be careful with this medication, though, because your body can actually develop chimeric antibodies to the medicine. So essentially your body's making antibodies to the medicine, and if you do have antibodies, that could lead to an anaphylactic type reaction. So patients have BMPs and uric acids checked every 2 weeks when they're on a medicine like this, and if their uric acid level should be undetectable on pegloticase. It should be less than 0.2. If it starts creeping up on you, then you have to start considering the possibility that the patient has developed an antibody and pegloticase is no longer safe for that patient. This is a medication that should be prescribed by rheumatologists, but it's something that it does have that severe risk for anaphylaxis. Now you can reduce the ability of the body to create chimeric antibodies by putting the patient on methotrexate and azathioprine. That's not something I've done clinically, but it's something that you could consider. We talk about at our conferences. Okay, this is something that's very important. So if you've got somebody that's on azathioprine, and always be aware of that interaction between azathioprine and allopurinol. It can lead to severe neutropenia, pancytopenia, very toxic to the bone marrow. So thinking about that. All right, so that's gout. That's it's a very interesting disease process. There are others that mimic it. So, there are other microcrystalline diseases. And the second topic I'd like to talk to you about is, pseudo-gout, or calcium pyrophosphate dehydrogenase disease. So presentation, it can resemble gout. It does differ in some ways. Usually it's an acute arthritis, commonly involving the wrist and the knee. You're going to have a lot of local heat and erythema, but attacks tend to be self-limited. And if you've had one pseudo-gout attack, it doesn't mean that you're going to continue to have flares. It may have been precipitated by trauma. There's a lot of things that can precipitate a pseudo-gout flare. It doesn't often lead to a chronic illness, though, so they don't need to necessarily be treated other than for that flare with prednisone or colchicine or an intra-articular injection. But you should be aspirating their joint, and we're going to take a look at chondrocalcinosis on some x-rays in a minute. But in terms of you aspirate the joint, you're going to see these, you'll see calcium pyrophosphate crystals. They're rhomboid shaped, positively bifringent. I'll show you pictures of that in a second. But again, you always got to consider a septic joint. Now, here's another take-home point that I really want to drive home. Gout and pseudo-gout can coexist. Gout and septic arthritis can coexist. And, pseudo-gout and septic arthritis can coexist. They're not mutually exclusive. So when you're tapping somebody's joint, you should always be sending it for culture and crystals and synovial fluid analysis. Talking about that, we also get cell counts. And, well, what's an inflammatory fluid? More than 2,000 is inflammatory, less than 2,000 is not. But people tend to have, in the pseudo-gout, gout range, they could be anywhere between 10, 30, 50,000. They could be all the way up to 100,000 cells. Septic arthritis tends to be, also very high. There's no number, but I mean, they could be up to 50,000 or 100. So it doesn't make a diagnosis. It just kind of guides your thought process. But always send your crystals and culture and gram stain and all that stuff. And if they've got risk factors for Lyme, Lyme can present similarly an inflamed monoarticular or oligoarticular arthritis. If it's the right season, you can actually tap the joint and send it for Lyme PCR. So that would also be of utility if it's the right time of year. The other point I want to make is, chondrocalcinosis is an X-ray finding. It does not make a diagnosis of pseudo-gout. Okay, so there's, in terms of epidemiology, there's no male to female predominance. CPPD can involve anywhere between 4 and 7% of the population, and it gets more common as we go along, as we get older. So it's something that can happen with increasing age. Now, just because somebody has, this is for chondrocalcinosis, mind you, that doesn't mean they're necessarily going to get pseudo-gout. So, somebody that has asymptomatic CPPD, you do nothing. You just follow it. You note it. But somebody that has an acute flare of monoarticular or oligoarticular arthritis, thinking about, should you give them an injection? Should they be on a steroid taper? Do we need to consider colchicine in a more chronic scenario? So something that, like I said, can involve the wrist and the knee, can involve the shoulders, ankles, feet, elbows too. And it can last longer than gout. Like gout, I would expect to go away in 2 weeks, even if you did nothing. Pseudo-gout could last for months, 2-3 months even, especially if it's a severe flare, if you don't treat it. So, that's a consideration as well. Trauma, surgery, and other medical illnesses can lead to flares. Parathyroidectomy is very notorious for causing flare. Bisphosphonates and these granulocyte macrophage colony stimulating factors have been reported to cause flare. And another scenario, chronic CPPD. Some people kind of refer this to pseudo rheumatoid arthritis. This could probably be mistaken for palindromic rheumatism or seronegative rheumatoid arthritis. I've caught a couple cases where I thought somebody had rheumatoid arthritis and I ultrasound their hands, and lo and behold, I'm seeing, calcium deposition in their wrist, and I'm starting to rethink my diagnosis. So somebody that has chronic CPPD, especially if it involves the hands and the wrist, and that can fool you. Typically it's not erosive. You can have morning stiffness and synovial thickening and local edema, but it is certainly a mimic for RA. And the problem is that it can wax and wane. So, but if they're on treatment, you'd think they're just you'd think they'd be in remission. And if they're flaring in spite of treatment, and, you've tried a bunch of other things, maybe considering sending them for an MRI or an ultrasound to look for the presence of this, or even just an X-ray looking for chondrocalcinosis. And that's a very uncommon, presentation of pseudo-gout. Less than 5% of patients will present this way. Every time you have a pseudo-gout flare, you're destroying your joint, and that can predispose you to OA. And then in severe scenarios, you can have someone that has such terrible joint destruction, it could make you think of a Charcot joint. This is a very interesting scenario. They teach rheumatology fellows on our first day. We all go to Penn, at least the ones on the East Coast, and we get a lecture series, and they talk about this, spinal involvement of pseudo-gout. I'll show you pictures of Crown-Dens syndrome in a second. But, it can cause spinal involvement, calcifications of ligamentum flavum and posterior longitudinal ligaments. And, Crown-Dehn syndrome can lead to an acute cervical pain, shoulder girdle pain, fever, elevated inflammatory markers. You can see this with CPPD and also basic calcium phosphate disease, which we'll talk about in a second. The other thing I want to tell you guys is another important point. A lot of my inflammatory arthritis conditions will not cause fever. I mean, they can. Rheumatoid arthritis and psoriatic arthritis, and most of those will not cause fever. Sarcoidosis does not usually cause fever, but gout and pseudo-gout will, okay? So just because somebody has a fever, it doesn't automatically mean they have an infection. Gout and pseudo-gout patients will fever, okay? So just keep that in mind. And now if somebody's got, pseudo-gout before the age of 50, thinking about, other secondary metabolic derangements like calcium abnormalities or phosphorus abnormalities, alkaline phosphatase can be low in patients that have hyperphosphatasia, which is a risk factor, hyperparathyroidism, iron, hemochromatosis is, a condition commonly associated with pseudo-gout, and thyroid disorders, both hypo and hyper. So here's a picture of someone that has chondrocalcinosis. And, this is your TFCC right here. That's a great place to look for evidence of chondrocalcinosis. You can see these white lines in the cartilage and joint space. And on the knee, that's another great place to look. I've ordered x-rays on the knee. If somebody's got a flare in their hand, if they don't have, and I have no idea what they've got. If they've got CPPD in their knee, you start, at least that entertains it for being on the differential. If they're having wrist inflammation and you can't get a tap. Here is another ultrasound of someone on the left. It's actually going to be a knee in maximum flexion. And I think I showed you that picture, what the double contour sign looks like in gout. Well, this would be the pseudo double contour sign of pseudo-gout. And this is actually someone's femur. On the bottom line here, you can see the femur, and then you've got cartilage. And then kind of running through the cartilage, you've got this hyperechogenicity that is the pseudo double contour sign. If it was the double contour sign, you'd see it kind of lining kind of right underneath the quadricep. We shouldn't see any articular cartilage on the top here. So it's kind of running through the cartilage instead of like on the surface. So I call this the pseudo double contour sign. And this is somebody's medial meniscus. This is your meniscus, and you've got calcifications on there, tibia, fibia. So that's another place pseudo-gout likes to hide. Crown-Dehn syndrome, very rare. I've never seen this clinical entity, although we do talk about it as rheumatologists. And this is the CAT scan of someone's atlantoaxial region right around the dens here. You can see in the sagittal view, you've got a calcification. And in the cross-sectional view, there's a calcification here. So if you see something like this on CAT scan, somebody's complaining of neck pain, fevers, it can actually mimic meningitis, but if we see this, entertaining Crown-Dehn syndrome as a possibility. And, rheumatologists are always taught, when in doubt, tap it out. Okay, so if you've got an inflammatory arthritis and you've got an effusion, very important to perform an arthrocentesis. And you can see here, this is somebody that's having an acute flare of CPPD. You've got, these positively befringent rhomboid-shaped crystals in the joint space. And here's another huge point. These are easily missed, okay? I can't tell you how many times, when I was in fellowship that, the lab reported no evidence of crystals, and then we take the synovial fluid sample down ourselves and we actually see, very faint positively befringent crystals. They can be very small. They're very easy to miss. So, it's something, if you've got somebody that's got inflammatory arthritis in the knee or the wrist, you have no clue, there's still an effusion, and taking a trip down to the lab and having a look yourself. In terms of, pseudo-gout, you can use NSAIDs, you can use intra-articular injections, oral steroids at similar tapers as I was talking about before. And if somebody has chronic, like that mimic of RA, that, gout and the MCPs in the wrist, you can always consider putting them on colchicine 0.6 milligrams PO daily or BID, depending on how bad. So that's another, treatment modality that you have. All right, and then kind of our last topic, this is an extremely rare entity, basic calcium phosphate disease. Maybe it's probably not as rare as we think. We're not very good at detecting it, and it's an arthritis, basic calcium phosphate disease. There's 3 different crystals we think about: carbonate, substituted hydroxyapatite, octocalcium phosphate, and triacium phosphate or trialcium phosphate. These are the basic calcium phosphate crystals, and they predispose patients to RA. And I remember reading a statistic somewhere that even close to 20% of people that have end-stage OA in the knee, if you test their synovial fluid, they could have basic calcium phosphate crystals in that fluid. Associated conditions with basic calcium phosphate disease is calcific periarthritis and calcific tendinopathy. We see this a lot in the shoulder. But then there's the infamous Milwaukee shoulder. I don't know if we still test this on internal medicine boards, but it's it's somebody that has chronic inflammatory arthritis in the shoulder, and they've got a large effusion, and they've got signs of OA in the glenohumeral joint. They may have signs of a high riding humeral head in the setting of rotator cuff pathology or tears, and they have large effusions. And I have to tell you, a shoulder effusion, there's no mistaking it. You can't miss it. It's huge. It's like somebody has a water balloon sitting on the front of their deltoid, and it's very easy to blot. And when someone has a shoulder effusion, they're usually large and very easy to drain. If somebody has Milwaukee shoulder, ironically, you're not really going to have an inflammatory appearing fluid. It may appear non-inflammatory. And the crystals are very small, and they do stain with alizarin red, but that is not specific for basic calcium phosphate disease. They are sometimes shaped in crystals, and you could be looking at a fluid sample with greater than 1000x magnification and still miss it. Some conditions that Milwaukee shoulder is associated with: myositis scleroderma, but also end-stage renal disease. So pathogenesis of basic calcium phosphate disease not fully understood. You can have BCG mineral formation at other sites that can cause local tissue damage. Basic calcium phosphate disease tends to involve joints that are overused. How you have an old injury, and average age is about 72 years of age, and it's more common in elderly women. And like I was kind of alluding to, you can have, it's really hard to find these on microscope. Very difficult to find them. They're very small. And it is associated with bursitis, tendinitis, and enthesopathies and OA. And there's a hereditary component of calcium apatite crystal disease. It's kind of outside the scope of this talk. Treatment: NSAIDs, local steroid injections. People that have chronic renal failure or parathyroid ectomies or phosphate deprivation, transplant patients are at risk, and a lot of patients that have basic calcium phosphate disease end up needing a joint replacement. Here's a picture of these coin-shaped crystals that are stained with alizarin red. And kind of to wrap up, there's two other kinds of crystals. Both are kind of interesting. I saw them both in fellowship. I actually wrote a case report, and I presented it at our national meeting as a rheumatology fellow. Now, we had a guy in his 50s who was having fevers. He was having inflammatory arthritis symptoms, had an effusion in his ankle. We were consulted. I think we were all thinking gout. Or pseudo-gout or something, and I ended up tapping this guy's ankle, and this came out, and it was very, very kind of milky, almost kind of appeared chylous. I showed it to the infectious disease attending. He's like, "Oh my God, culture that." So we did. Nothing grew, and I got a call from the lab, and they basically told me that the sample was too thick to actually send off like a cytology, like a cell count. They had to dilute it and dilute it and dilute it. So they couldn't really get a cell count on it, but I went down to the lab and I took a look, you know, at the crystal. You know, I was looking for crystals. I thought I was going to find gout, and I found this lipid crystal. And lipid crystals are associated with people that have fractured a bone, but in this case, the patient actually had really severe pancreatitis, like chronic pancreatitis. They ended up getting a CAT scan, and he did have pancreatitis on the CAT scan. We actually sent the synovial fluid for amylase and lipase, and it was through the roof. So, you know, this was a mimic, you know, of a common disease. You know, pancreatitis, very common. How many times have you seen it cause a necrotizing inflammatory arthritis? I mean, this guy's pancreatic enzymes were digesting his synovial membrane. Pretty severe. But, you know, we did the arthrocentesis. We took it down to the lab. We did our due diligence. We looked at it. Something didn't seem right. And, you know, we were able to kind of come up with this diagnosis. This is a cholesterol crystal. I've actually seen this clinically in a patient that had mixed connective tissue disease and had olecranon bursal, inflammation. We ended up doing a tap, and you got these crystals here. They kind of represent it. They're very amorphous in shape. They can be either positively or negatively bifringent, and they kind of look like the shape of Utah. I think this picture kind of really gives you that appearance. So that's a cholesterol crystal. All right, so here, I hope I haven't bored you guys to death. These are my references, and if anybody has any questions, I'd be happy to attempt to answer them.
So just a couple things. I'm back here. If you can complete the evaluation, again, it is in the chat box. We would really appreciate it just to hear what you thought of the program and give us any suggestions or comments on future programming. What else? Yes, if you have any questions, you can fill out the blank. The arrow should be up. You can just type on the question and Dr. could speak. You could also unmute yourself. That's another possibility if you have a question. And thank you so much, Dr. Torelli.
Oh, it's my pleasure.
I really appreciate you coming out, and very good talk. I didn't understand something, but so let's see if anyone has any questions. Does anybody have any questions? Again, you can either unmute or you can type your question in the chat box. No questions?
No. I think I bored everybody to death here.
Oh, here we go. There's one. Are there foods that naturally help to control gout? That's a good question.
So yeah, it's an excellent question. So tart, we sometimes recommend tart cherry juice to patients. Is it going to eliminate their need for medication? No, but it can be helpful in certain scenarios. It's more about dietary avoidance, really. That red meat, shellfish, alcohol consumption, sometimes like soda, really sugary foods can precipitate flares. So, I like to recommend the Mediterranean diet to a lot of my patients. I think it's a pretty healthy diet, low in red meat. But tart cherry juice would be the answer to that. I think that does have some role for gout patients.
I have a question. Can anybody hear me though?
Yes,
yeah.
We can.
Oh, you can hear me. Great. I had a really bad gout attack the first one that I had, and I didn't know, I was kind of misdiagnosed. And now I'm using daily medicine with the allopurinol. But I have still really bad residual swelling in the toe, and I guess that's tophi. I don't know, is the best way to get rid of that through medicine or through surgery?
So surgery is not the answer. Tophi will come back. So if you I haven't looked at your foot, but if there's a tophi there, that surgery is not the answer. Removing the tophi will just come back. In terms of management, if you have gout, just getting your uric acid level to goal. I don't know what your uric acid level is, but making sure that it's less than 6 or less than 5 if you've got a tophus or erosion. That would be the main thing. You can still have flares of gout on some dose of allopurinol if you're not on enough. So that would be the major consideration. You know, if I've got somebody's uric acid at goal and they're still telling me they're having gout flares, then I'm starting to reconsider the diagnosis.
What's the goal? To have it under 6?
So the new American College of Rheumatology recommendations is to, you know, check uric acid levels monthly and, you know, increasing allopurinol by 100 milligrams until you get to the uric acid level of less than 6. And that was just the new guidelines of 2020. Like I've said, anecdotally, I've had patients that have tophi and erosions. The old goal used to be less than 5 if they've got erosions and tophi. I still do that. If someone has erosions in tophi, I will bring their uric acid level to less than 5 because I've seen people flare gout with a uric acid level in the 5s and they've got erosions in tophi.